So I hope it's an interactive session. I will just talk for the first like 20 minutes. I also want to thank my collaborators from the Institut Pédiatrie Sociale and from the London School. I will tell you about a tool that I've been adapting for health facility assessment on MAMI in Senegal, and how we are hopefully going to use this tool in our current implementation project. And that's really where I want your feedback and our discussion to be on. So we started outpatient nutrition care in a large primary care clinic in 2014. Just a bit of my experience there. There were not any like tools or registers. The nutrition register, when it came out, it started at 6 months. So we were not allowed by the district to even register the infants that we treated. So we designed our own forms and tools. And just one remarkable thing is that there was just a lot of psychosocial issues. I think MAMI practitioners among us, they would agree on this. We had mothers that were like having unwanted pregnancies, were adolescent, they were ill, there was poverty, some were living on the street. So each MAMI infant that we had in our care was like, you really needed, it was not a routine care, you needed your full attention on each one of those infants. So that's really where my love for MAMI started. And yeah, that's where it started. Maybe a little bit about Senegal, for those who don't know the country. Senegal is a stable country in West Africa. They've been really doing well in progress in reducing infant and child mortality. Malnutrition rates are actually not very much going down. And this last DHS, there was wasting, was at 10% again. So there are some underlying factors that even though there is fast progress in the health system, innovation and development, there is some underlying things where I think MAMI can come in. The under 6 months, the latest DHS wasting was 6.4%. And the weights, 10 and 15% self-reported low birth weights. And the breastfeeding rates are actually, not going up and even going down. So Senegal is currently working hard on adapting the new WHO guideline for acute malnutrition and integrating a lot of MAMI aspects in there. In general, they're working really on having the clinical guidelines more in the picture. They have a multi-sectorial nutrition strategy. Universal health coverage is a big term, but to be honest, in Senegal, most people still pay out of it. Primary care facilities in Senegal offer care for infants under 6 months, I think like in many other countries. So around the delivery, postnatal care, vaccination program, IMCI, community health. So I just put like 5 contact points that will come back later, where many infants pass in the primary care system. And actually the coverage is quite good. So most mothers deliver in a health facility. They do a couple of postnatal visits, vaccination programs are well visited. So that's all good. So MAMI research, I'm not going to go too much into this, but we did a couple of projects, some qualitative study on outpatient or inpatient treatment within our own clinic, and also an international stakeholder consultation with Senegalese collaborators. So I'm going to share some results from a study we did a couple of years ago for my PhD. And this was really as the objective to measure general primary care readiness and measure also the MAMI readiness and evaluate opportunities for MAMI implementation at each of the 5 contact points that I just showed. And I think most of us are kind of familiar with facility assessment in general, with tools like SARA or SPA, which are quite well known. And they're based on a theory from Donna Bedian that is, you're basically not measuring outcomes such as health or knowledge or behavior, but you're really measuring the structure and the process to get to the outcome. So the structure is more the infrastructure, equipment, resources, organization, and the process is more like the diagnosing and treatment. The WHO recently came with a new tool, the HHFA, Harmonized Health Facility Assessment Tool, which is very ambitious. It's supposed to replace the existing tools and be really useful in adapting to whatever country or context it's needed, with a very sophisticated data management system on the website, with a platform where you can just select the indicators you want. So that's the HHFA for those who don't know it. So in my study, I used version 2. So right now they're on to version 4, I think. And it's basically like a long list of items and indicators, thousands of them. And I selected those that I thought were relevant, well, with a couple of Senegalese colleagues that are relevant for our primary care system here. 137. And then I took the MAMI care pathway and created a domain specifically for MAMI, which we based on some, there are a couple of existing service-specific domains. So at that time there was vaccination, postnatal care. Right now there are many more service-specific domains, but we use it as a base to create a MAMI domain with 41 items and added it to the rest of the questionnaire. So this is, yeah, I want to go quickly through this list. At the left side, you see the primary care items. So it's HHFA is divided into 4 dimensions, they call it dimensions, and then areas and sub-areas. And I have listed the number of items that we selected and the methods. So it can either be a register, so you're looking up in a register, it's a direct observation, or it's an interview question. Those are the 3 methods. So within general service availability, there's health infrastructure, there is health workforce, there is service availability for general primary care. Then there is general service readiness, which includes amenities, basic equipment, infection prevention, diagnostic capacity, so what diagnostic tests are available, and a couple of essential medicines and commodities. Then there is a management and finance part, which is all about governance, finance, support systems, quality system, information systems. And then there is another domain that's called quality of care. And it's for now only includes record review, so checking what's all recorded, but we added here an observation of care to this domain. And then at the right, you see the MAMI tool we created. It's about infrastructure for MAMI, it's about health workforce, and the availability, we split it up in 3, like assessment for MAMI, classification, and treatment. This is from the IMCI way of thinking. And then the equipment and guidelines and training. And for all these lists of items, we check them, we assess them at each 5 of the contact points. The sampling, we worked in 3 districts. There was convenience because that's where we had the best relationships. And then within the district, we randomly selected 5 health post primary care clinics to do our surveys. And we interviewed the one at the health facility that is most knowledgeable. Most of the times it was the head nurse or the midwife or both of them, whoever could answer best the questions. And also look at the registers and look at some observations of care in the building. It took us like 1 to 2 days, usually 2 days, but it's more because of building trust. So the first day, really getting to know the people, and then the second day you could do more into observations without being really insulting or having people think that you check on them. So the results, at the left you see the general scores for general availability was 50%, general readiness was 69%, management and finance 50.2%, quality 47%. And then you see at the right the MAMI scores, which are 47.9 and 27. It's low because it's also not fair, because you're kind of assessing a health service that's not been implemented yet. So it's really to show like whatever is there already is kind of a basis where we can start our implementation and gives an opportunity for implementation. And here you see the 5 different contact points. So delivery, postnatal immunization, sick child clinic, and community health. And on top you see the patient visits per year. So of course, immunization, there are multiple visits, which just gives an impression of like infants under 6 months, they are just frequently at those contact points. What you can also see is like between the assess, classify, and treat, the classify, the yellow one is really the lowest. And that's what I can better explain with this a little bit full table. So here you see the full list of items for the MAMI part listed out. So, for example, the infrastructure, open minimum 5 days a week. You see most contact points are available 5 days a week. Immunization is once a week. Community health, usually just once a month. Health workforce, it's about the number of health providers, but also about their level of training. And you see that midwives are well trained to do the care. In some other contact points, people are lower trained. And then if you look at assessment, you see that at delivery and postnatal care, there's quite a deliberate assessment taking place of infants. So they take weight, length, MUAC, physical exam. They do a whole lot of assessment. The midwives at sick child clinic as well. There's a physical exam, their nutritional status. But then when you look at classify, it's much more red. And basically, midwives, they detect low birth weight, and at sick child clinics, they detect wasting quite systematically. And all the other indicators were really low. And then for treatment, it's interesting to see that breastfeeding counseling is actually happening in multiple contact points already to a certain extent. The same for referral for complications. It's interesting to see that formula prescription was quite common by midwives already. But things like psychosocial support was really low. And then when you look at equipment, infant skills were there, but not most of the time, not digital. The growth charts were mostly absent. And guidelines and training, the IMCI guideline we found them quite regularly. Breastfeeding guidelines or visual aids were used frequently by midwives. And training, I just listed a couple of trainings that somehow include aspects of MAMI. It's of course not a MAMI training, but IMCI, immunization and malnutrition training were quite commonly followed in Senegal. So to conclude, general primary care readiness is high in Senegal. The 5 contact points are well attended. Our MAMI survey showed suboptimal readiness, but there are a lot of structure and process items already in place that could reinforce implementation. So there I want to go into our current project, which is about MAMI implementation research in Bangladesh and Senegal. And we are going to set up a couple of MAMI demonstration sites and document learning. And we want to use the HHFA MAMI as part of our implementation strategy. Has this been done before? Most of the time when people use services, facility assessments, they use existing past surveys to evaluate. But really in implementation, I have seen 2 examples, maybe there are more, like the Nest 360 used it for small and sick newborn care, a baseline assessment. I'm not sure if they really repeat it. And also concerned that a more nutrition-focused health facility assessment with really in mind to implement or improve care. This is just a long list, just to show that the HHFA and health facility assessment, it's originally created to really design programs, and it's for policymakers. It's usually 1 to 2 days. You need a sample that is representative for a whole country. Some countries do it every 5 years, and it's really for advocacy on national policy level. So if you want to use it in implementation, it's going to be different. It's, you might need a smaller scale sample, just whatever is relevant for your implementation. And it might be better to do a shorter survey and maybe do it more frequently. And it's more about the individual health facility to give feedback than about a whole country. And this is recently being piloted by the FAST-R whatever project. So they have a rapid cycle health facility assessment with a shorter list of items, and they do it by phone. So they just phone the health facility on a regular basis, and then they take their learning and they act and analyze. And the idea is that it's cheaper. It's much cheaper, and it's can be more focused on one aspect of care, and it's supposed to really strengthen implementation. So within our study, we are trying to figure out what to do and what is best. And that's kind of the steps that we are planning to take. So first, we really need to reframe, like, what is the purpose of our HHFA MAMI? What are we going to use it for? Is it a one-time assessment at the start of our implementation research, or are we going to do a rapid cycle by phone? Or it really depends on the purpose for us in Senegal and Bangladesh, but also for you in the wider MAMI community. And then the indicator evidence base, we really want to stick to the HHFA. There are other tools that kind of adapted a lot or mix different tools, but we really want to stick to the original HHFA, so it will be comparable between countries and between projects. And also use the MAMI care pathway, of course, still for the MAMI aspect. Then the criteria, how we're going to make the selection, it's all going to be based on feasibility, usability, but we're also wanting to do like a stakeholder consultation, maybe with this group or a wider group to speak into this new phase of the tool. And then we want to pilot test it within our demonstration sites. So we're really at the first step, and that's what I want to. Maybe there are questions first, but really I would like to discuss and learn from others who have done this before, have experience in facility assessment, or who are involved in implementing MAMI in their country. Like, how could a rapid or a longer facility assessment be helpful in MAMI implementation? So that's my question. But thank you.